Global Health Conversation Series. I am Dr. Arlene Calvo, Associate Professor at the College of Public Health of the University of South Florida, and I'm based at the City of Knowledge in Panama City, Panama in Central America. Welcome. We will be recording this session. In case you missed some parts of it, you will have access to it in YouTube, and we will also be sending participants who registered for this session the link for the recording. Today, we're very happy to have our colleagues visiting us, where we're going to be discussing important topics related to migration and access to health. Our first speaker is going to be Dr. Roberta Villalón. She's a professor. She is in the Department of Sociology and Anthropology at the St. John's University, and she's a Latin American feminist activist scholar. We will be discussing with her transnational migration and health access. We also have with us this morning Dr. Beatriz Padilla. She will be discussing migration as well, but with a highlight on transnational migration and health access. Dr. Padilla is an associate professor. She is currently the director of the Institute for the Study of Latin American and Caribbean Studies, Department of Sociology at the University of South Florida. We both collaborate with an initiative called Salud Latina. So I'm very happy to have you here with us. We're going to have first a Q&A introduction on these activities, followed by a very short presentation by each speaker, and then we'll go back to Q&A. Please feel free to write your questions in the chat. We will be responding to all of your inquiries as we go through all of this very interesting material. So first of all, we have observed wave. If you could stop sharing the presentation now, please. We have seen an increase in migration in the recent years, not only in Latin America, but worldwide. And I wanted to start with a very simple question, but I think it's important so we put things in context. And let's start with Dr. Roberta. Why do you think, or why do you know, based on your scientific research, that people tend to migrate?
Good morning, everybody, and thank you for having me here. And this is a very important question that we tend to kind of dismiss or think that is taken for granted. So why do people migrate? And this is something that, of course, is difficult to kind of generalize, but still there's trends and there's scientific research about why it is that people all over the world have been migrating for years, right? So to begin with, it seems that it has been the most natural type of thing to do was to migrate from region to region to be able to find the resources necessary to survive, right? So being a nomad was kind of a norm for many, many years. Now, once we've settled in different places, people have continued to migrate. The reasons are mostly three. The first one has to do with the need to find better conditions to be able to thrive and survive. The second one sometimes is more related to being connected or being reunified with family members that have migrated before, right? And the third one has to do, of course, with critical issues or crises that have emerged in the environment that people are living. This would include things like wars or hunger or environmental disasters, etc. So people in general are pushed for different reasons out of where they live, and they do this migration sometimes without the certainty if they're going to return or not, but the certainty that they have is that they need to migrate in order to be able to survive.
Thank you so much. We know that the numbers, like I mentioned at the beginning, have increased. In the year 2020, we saw about 281 million people migrating worldwide, and that was an increase from the prior year, 2019, from 272 million people. And I think it's fascinating that even during the COVID pandemic, when we thought people would stay home and in the lockdowns that we saw in many countries, the very strict lockdowns, but that was not the case. We saw an increase of migration that year. Based on that, what are the main routes or that people tend to follow to migrate? We know that it's not simple. And when we talk about migration, we have to have clear that it's not something that just happens overnight. It's a process. People start from their home country, they go through different countries and different regions before they achieve their country that they would like to be based at. It tends to be the US, in many cases in the Americas, and in Europe, it tends to be more the northern part of Europe. So what are the main routes that we see people following during these large migrations?
Okay. Thank you, Dr. Calvo, for bringing this relevant question. So before I get into mentioning, describing some of the routes, I think it's also important that we mention or maybe say who is a migrant, right? Because sometimes we are taking it for granted, and there are different definitions of migrants. So I would like to state that some of the definitions of migrants come from the International Organization for Migration, but also countries or states define who is a migrant. So there are different kind of definitions. And these definitions might have an impact, especially on migrants' access to health services. So in some countries, up to 3 months, you are considered a tourist. So having access to services could be a challenge. Most countries also, and according to some of the measurements by the IOM, consider migrants someone who has been abroad for over a year. So you see that this, that this definition might have an impact. And then if you take a look at the different kind of migrants that you can even get from what Dr. Villalón described, you have economic migrants, but there are also many other categories that are relevant and that have become even more relevant in Latin America. So in addition to the economic migrants, we have refugees, we have asylum seekers, we have displaced people, and the displaced people can be internally displaced or displaced to different countries. As the ones that we are much more familiar right now in the Americas are the Venezuelans. And so this could be, relevant issues. Now to move to the routes, it is important to understand that migration is a global process. So there are global routes that are established, but we can start for the ones in the Americas. So in Latin America, as you mentioned, also the United States having the traditional country of destination, and even before the 50s and the 70s, and the traditional route used to be much more Mexico and the US. But we can also look at the whole continent and see different intra-regional routes that mainly used to be mainly used to put in contact neighboring countries. So there would be in the regions and countries that would tend to attract more migrants, like used to be Venezuela, Argentina, Costa Rica, and then the neighboring countries would move to those countries. But that has been changing more and more. And now we have some new migration countries, like, for example, Colombia, that all of a sudden became a destination country for Venezuela, but also Ecuador, Peru, and Chile, that used to be mainly more country of immigration. So all these routes are changing. Brazil also became a country of immigration, receiving a lot of the Haitian that left Haiti in 2010 with the earthquake. So we see that things that happen around in the world and in specific countries generate new routes. And we can also see how some political agreements or that have been taking place, for example, Mercosur, generated a new scheme of mobility around these countries that kind of were imitating or mocking what happened in the European Union, that generated more European mobility. But also we think about some extra regional mobility or routes. We can think of the colonial links, so the former colonial links. So you have Latin America migrating to Spain and Portugal in that sense, but also other links that have been generated previously, even centuries ago, when Europeans migrated to the Americas. So for example, Italy had been, or France and Germany. So that would be to think about the Americas and Europe. But also we have international routes or global routes. And we know that each continent has their own. Asia is a country where is a continent where a lot of migration takes place, and then we see transition countries that also are changing. For example, Mexico, that used to be like a transit country for Latin Americans or other migrants coming to the United States, that has been changed, and now Mexico is a country of immigration, because a lot of the Latin Americans and a lot of the migrants are coming from around the world are in Mexico. So routes, they might change, very suddenly. Or, for example, Morocco has become, or Turkey have become countries of immigration, because that's where a lot of the migrants that are going to Europe or are going to somewhere else kind of get stuck, right? So I think that this gives an idea of the different mobilities that are taking place.
Thank you. Thank you both. I wanted to share some numbers with our audience just to show the implications of the world migration. This is a recent data report from the International Organization of Migration, and it has the categories that you were describing before, Dr. Padilla. So for refugees, we see globally around 26.4 million people. Asylum seekers, more or less 4.1 million. Displaced Venezuelans, 3.9 million, and internally displaced persons, 55 million. So we are talking about very large numbers of people who are leaving their countries, their communities, their families, their homes, and this is important to understand. So this leads me to my next question, and it is, we're putting our scientific thinking caps on now, and I wanted to start with Dr. Villalón, and I wanted to ask her, why do we study migrations? What motivates people, the positionality, and how do we study them? What methods do you use to study migration?
Sure, and I think that in some cases, really, our identities or positionalities and experiences will shape a little bit our research interests. And so if we have been involved with migration directly or indirectly, we may be inclined to try to understand better all of the complexity that these processes of migration entail, right? But of course, some people just study them because it's interesting, and they are processes that are relevant for public policy for different reasons, right? It's always shocking for a country or a community to receive a larger number of migrants, especially if they were not used to receiving a large number of migrants. And this raises concerns related to how can we properly handle, right? An influx of people who have not been receiving services or being part of our communities. How can we deal with that? So there are different motivations, right? Now, in terms of why I have been studying migration specifically, right? It was a combination from, I think, like two main factors. The first one was really that I migrated, and I eventually started to try to think, well, how is it that this is affecting so many other factors, and how is this is, you know, interlaced with different other processes, right? Including issues related with racial and ethnic identity, gender aspects, social mobility, and socioeconomic status, but also just simply like, how is it that our well-being is being affected by migratory processes? So I got involved in different organizations that were providing services for migrants, and that was, you know, like really the door that was open to me to understand that this is really a very complex and nuanced process. So for me, what I was finding in the literature, while useful, was limited, right? Like, numbers help us, but at the same time, don't tell us all the story, right? As a sociologist, I wanted to be able to get a better understanding of the nuances of this process, of the texture, of the complexities. And so sociological research allow us to do that, because we always think about the historical processes beneath what we're seeing in the present. We are always paying attention to the politics involved in this process, both the kind of the official politics and the politics that we do on a daily basis. And that vantage point is really helpful to, in a way, bring bodies, right? Bring body to these numbers. Another advantage, and has been part of my methodology, was that as sociologists, like, it's a discipline that is inherently interdisciplinary, because in a way we've been always borrow from different fields to understand fully, right, the social processes. We borrow from psychology, from economics, from political science, etc. So the approach is interdisciplinary because there's no way we can capture everything if we're just looking at this problem from one perspective. So if we look at migration from the legal perspective, we're just going to be highlighting whether the migration was regular or irregular, where the policies available are hindering or preventing or motivating people to move, right? But we are going to be losing perspective on other issues. Similarly, if we just take an economic perspective of migration, we're gonna focus either on the negative of people are coming to steal our jobs, or people are here and how are we going to redistribute resources, or on the positive saying, hold on, people come in and they work, and they're working and contributing to the economy. They're also contributing to the economy back home because of all the remittances. They are, you know, very prone to send as quickly as they can. And so that again paints just a portion of the picture. So as a sociologist doing interdisciplinary work, we really like to bring a holistic understanding where we're paying attention to every facet: economics, the law, public policy, health policies, health aspects, anthropological issues related with, as I said earlier, issues of transculturation, for instance, and psychological aspects, because it is a very psychologically taxing process to migrate. So how is it that psychologies of migrants and those who are staying behind are affected? And we try to put all of this together, right? And as a segue to Dr. Padilla, who's going to also address a little bit more about the different types of methodologies that we use, right? We can combine quantitative and qualitative methodologies, of course, as sociologists, and we do, right? We try to put all of this together, But specifically on my work, similar to Dr. Padilla, we've been taking what's called an action or an activist approach, which means that we are working together with the communities, with the organizations that are involved in providing services or taking care of things related to migration. These organizations can include governmental organizations as well as nonprofit organizations, non-governmental organizations. And the idea is that we make sure that our research agenda is in tune, right? And is designed together with the communities or the groups that we are trying to work with to address whatever issues are of importance to them, instead of just doing the research for our own sake or doing the research for, let's say, other academics alone.
Thank you, Dr. Villalón. Dr. Padilla, following with this idea, this concept of participatory processes, activist research, can you explain further that type of research, how we would apply it to migration research? You are in mute.
Yes, I was unmuted. I'm sorry. So I think that working with migrants population is a perfect venue to apply either activist research or participatory action research, or in general, it's called the family of action research. And the possibility is because most of the time, or up to sometime recently, migrants were seen either as a problem or also as just subjects, but not necessarily as participants. And it's very important to include migrant population because they know better, they know the situation. Most of the time, or many times, researchers or teams of researchers were people from the country of destination who had no idea about the cultural differences, the political differences, even the policies that are in place or were in place in the country of origin. So the possibility of doing participatory action research or action research really increases the outcomes of the research. Also, it makes the process much more democratic. And also there are different ways to implement or to introduce action research in a research project. There are ways that you can make the full process action research, although that has also or may bring some challenges, because also working with population, with communities, sometimes brings some strain to the research. But you can also choose to add, for example, a specific action research for certain data collection, or just for results for dissemination. So that there's a whole array of options. And then even in action research, you can combine and use both qualitative and quantitative. But I think the fact that you have the participation of migrants is the most relevant. In my previous research, I have used this in different ways. One common way that has been used is to use what is called a community researcher. That community researcher kind of represents or is part of the community that's being studied. And you can do this with migrants, but as well with other communities. And certainly brings some advantages because someone from the community also becomes an active researcher. Also allows to bridge some of the problems that sometimes working with communities may bring when, for example, the research team does not speak the language, so the community researcher can act as a bridge, highlighting and contributing with the knowledge of, in terms of culture, but also in terms of language. So that has been used a lot. There are always some challenges, so that we need to be aware of that. There's another way, another path that I like to use, or a tool, and I have used the building alliances or community building methodologies, and these this has like an even broader impact, because in addition to bring along the migrant community, you make them also participant when you also build alliances with other society actors. For example, the state. If let's say you're working with the health system, you can bring the National Health Service if there is something like that, or you can bring hospital, you can bring the nurses. You can bring also the universe of NGOs that work in the field of migrant health. So throughout your research and as you're contacting not just the migrants, but also the different society actors that relate to migrants and health, you are putting them in contact. And this usually has the advantages also of providing some sustainability to the project, because most of the time what happens is we run out of money or the project is over, but at least you have some legacy for that kind of community building that the researcher was able to do in a specific case. So I think that that's why there are several good points of working with action research.
Thank you. We have a question that is relevant to this topic, so I'm gonna place it to both of you right now. Dr. Hoare wants to know, what are the ethical considerations when conducting research with migrants? What should we consider from a bioethical standpoint?
Mm-hmm.
Who would like to take that one first?
Okay. Okay. So, I mean, obviously, when we work with migrants, is the minimum that we do and we have to do, and it's a must, is obviously go through the process of IRB, right? And you will have to go through that process. But I think working with migrants is incredible. You had to be incredible careful, because a lot of the time, the way migrants are presented or are defined or understood as is as vulnerable population, and they are vulnerable population in many sense, but they're also population that have strength, that have capacity. So, and that's, I think that why including or migrants in action research could be also a way to not just empower them, but also give them a voice that many times is not normally given. You also have to be extremely careful, especially depending, I mean, anywhere you do research, but especially in the countries where if you're dealing with immigrants that are undocumented or might be facing special difficulties, you don't, you don't hold attention, or you don't misuse or misinterpret or misrepresent them in the research. And especially at the point of dissemination, this is very important, because sometimes anything that we said or the researcher says can be put in a different context, and you may be raising issues. And I think that sometimes you have to be very, very protective, and not everything can be said and published about immigrants and especially undocumented immigrants, because you can be, just like raising a red flag. So for ethical purpose, this is a very, very, you have to be very, very extra careful in that sense. Especially do not reproduce stereotypes, do not misrepresent them, which is that's how it is done in many cases. And that's, as Roberta mentioned, having cross-cultural research training is relevant. To avoid using your own culture to measure immigrants or to represent immigrants. So.
Thank you. We have 30 minutes left. I'm going to ask Dr. Villalón to share her screen and present to us her interesting research related to migration that she has been promoting these past few weeks.
There, do you see it? Yep. Perfect.
Yes.
Okay. So yeah, and please let me know when my time is coming to an end, so I can, you know, either fast forward or or add a little bit more things. What I'm going to be presenting now is mostly some highlights of a project that I worked on since 2015, and the last publication related to it came out in 2022, in September of 2022, which is this book, Migration, Health and Inequalities, Critical Activist Research Across Ecuadorian Borders. And this book really is just one of the products, and I think it's related with the issue of ethics that was just brought up and explained by Dr. Padilla, in the sense that when we're thinking about, when we're doing activist research and we're working together with different communities and organizations, there are multiple ways in which we need to disseminate our work. And this is really an academic book, but there's other things that we were able to do related to the work. One of them is a website that you'll see in a little bit, like a screenshot of it, that is called Salud y Migración, Migration and Health, that really explains in very accessible ways, and in Spanish in this case, what the main findings, right, of this research are. And then we've published different kinds of reports in different languages, posters, we've done radio presentations, and we've done TV appearances, and of course, we've used social media and the internet in different ways to make sure that we were able to reach, right, multiple audiences and the populations that were really interested in that were really interested, that they have, right, access to this information, and this information, or this knowledge that was really co-created with migrants, with people who are working in the field and providing services for migrants, and health providers that are working with migrants and have a special concern about migrant health. And really that was how this project began, which was that a group of medical doctors, nurses, and psychologists from the Institute of Health and Migration in Loja, Ecuador, invited me so I could work with them on designing some research to understand better why and how it was that migrations had affected migrants and the relatives of migrants that had stayed behind. Because this group of doctors were actually seeing how their patients, right, were coming in with different issues that they realized weren't necessarily medical, and they were wondering what's happening to them, and why is it that the solutions we're proposing are not working. So they really wanted to be able to understand better. And there was some information about this, very little related to Ecuadorians specifically, but there was information related to maybe Latin American migrations to the global north. We were able to contextualize and get some ideas, right, of what was happening and how it is that migration affects health and well-being. But we still wanted to be able to understand better the Ecuadorian case. And so we moved forward with this and approached the issue from a new perspective. We, as I mentioned earlier, we approach it from an interdisciplinary point of view. We did research that was transnational, so our project involved Ecuador, the United States, and Spain, and also both migrants and relatives of migrants that had stayed behind. We tried to approach the issue from a comparative perspective to both see how Ecuadorians or the experiences of migration to Spain and the United States, and also return migration to Ecuador, differ or were similar, as well as how this study specific to Ecuadorians applied or not to other Latin American migrants. And we did it from an activist or participatory type of approach, which involved working with different community organizations that, as I said earlier, right, provided services and work one-on-one with migrants, either providing migration services or health services. We took on theoretically this issue to try to bring another perspective as well. We combine different critical approaches, Latin American critical epidemiology, who's the one who developed the idea of the social determination of health originally, the critical medical anthropology, Latinx sociology, Black and post-decolonial feminist theories, and critical race and migration studies. And we can talk more about these theories, but just to give you a sense, what these theories brought were the capacity to emphasize the social, historical, and political dimensions of migration, health, and inequalities, to recognize the protagonism of migrants as opposed to emphasizing their victimhood or their lack of understanding of what's going on, to really base knowledge on migrants' experiences to be able to develop new theories and new understandings, and also the approach that we are creating this knowledge together with these communities for action, right? This is not just to ruminate, right? In academic settings, this is really to put our research into action. And the work we did was, as I said, 2015 to 2019, we did in-depth interviews, surveys, community workshops, professional trainings, open presentations, and we also always contextualized the Ecuadorian cases with other Latin American migrants who took similar migration routes. So that comparison allowed us to say what we found through our research specific to Ecuadorians is really something that also happens to other Latin American migrants who take these kinds of migratory routes. We are not ready to say this happens to every migrant in the world, but we know we can talk about this as Latin American migrants going to the global north and then sometimes returning home. And so we were able to put together and develop a framework of concepts that really describe better what happens to migrants and their relative when they migrate. And there's some health processes that we identify. They're listed here. I'm not going to explain all of them. I'm just going to point to some in a little bit, but just to give you a sense, we talked about reflective mourning, active and passive migrant trauma, and we call the migrant the person who leaves the active migrant, and the person who stays the passive migrant. Migratory stress, migrant crisis triggers, return shock, and migratory resilience or unrecognized migratory resilience. And then we have three different sets of psychosociocultural mechanisms, which were the ways in which migrants and relatives coped with different aspects related to migration. So for example, all of these we would not have been able to understand if we were not working together with migrants, because it was really based on their experiences, their understanding of their experiences, and also this work together, right? To say, how is it that we can think of these, right? That has become a pattern, that has been, something that shows up in all of you, that is a shared experience. So there were mechanisms to deal with how to process, right, to elaborate, to figure out all the effects of migration, paralyzing and motivating nostalgia, denied migrant health, normalization of malaise, pain encapsulation, the well-being ideal, transnational goals, and disillusion adjustment. There were coping mechanisms related with the relationships that had to be recreated between active and passive migrants, that sometimes they were like in different countries, sometimes then they were unified. So we talk about family de and reconstruction, communication distortion, subordination to concealment and deception, unspoken pacts, resentment and detachment, sensible comprehension. And then we have the coping mechanisms specific to return migration, strategic return, settling readjustment, and involuntary return rebound. And a couple of these concepts were really kind of reworking some of the processes that had been already identified in the literature, but most of the concepts are really coming from this particular project. So I want to just talk about now a few of these that I think may be relevant or important for you to take into account. But of course, right, there's really no process more important than the other, I would say. In any case, the first one I wanted to mention is the process of reflective mourning. And this is a rework of concept of just migratory mourning that Dr. Achotegui had developed, that talks about how migration is a process that generates grief, right? People grieve leaving their country, leaving their culture behind, leaving their people. And so this grieving, right, is just like any other grieving process, like occurs for a period of time, and then people kind of get over it, right? Or do their best to try to get over it and move on, basically, right? But what we found was that this mourning process or this grieving process in these cases involves something else. There was an element that wasn't present in the other definition, which is this process of being reflective, right? And thinking about once, right, people already are gone, or once their relatives are gone, it's just this reflection of why was it that we migrated? What was the purpose of that? And how these challenges have been affecting our lives, and how can we overcome them, and how can we come to terms with our new reality of being a migrant or a part of a migrant family. And in this reflection, there's kind of a reframing of the purpose of being and why, right, we're going to endure the different challenges and the different obstacles that may come up, while at the same time trying to see some of those opportunities. So we mourn, but we are not just emotionally, right, going through this. We're also very thoughtful about what's happening, and that thoughtfulness help us move forward. There's the active migrant trauma and the passive migrant trauma that I mentioned before. And these two are very important to think about, because no matter how smooth that migration was, migration as a process is traumatizing. And the trauma that both active migrants and passive migrants go through involves what happened before people migrated, kind of those causes that I was talking at the very beginning of this conversation. They're pushing factors that are moving people out of their places of origin, right, or out of the places of livelihood. And those situations are part of the trauma that migration and migrants bring, right? The second portion of the trauma, of course, occurs during the travels, right? And of course, we know that in the last few decades, migrating has become more risky, more challenging, more dangerous, okay? And this is an overall trend, okay? So even those, again, who may be going through migration in a smoother way, where they're choosing, they have a visa, they handle all of these aspects, the process to obtaining these proper papers, right, is very complicated. So these processes, especially when the journeys have been, including risk and physical attacks and debts, economic debt, so on and so forth, they can be very traumatizing. And the last portion of the trauma occurs once people arrive.
1 minute. I'm sorry.
1 minute, okay. So once they arrive, and when they arrive, there's also all of the traumatizing process of really transculturation, but also, of course, if there's discrimination along the fact that we're simply migrants, or the racial and ethnic discrimination, there's economic exploitation, and that can be traumatizing. And since I just have probably now like 30 seconds, instead of explaining anything else here, I just wanted to call your attention to this website, what you'll see here, Salud y Migración. We're working on the English version of this, but if you are Spanish speaker, or if you know people who are Spanish speakers, this is a really good point of entry where all of these coping mechanisms and health processes are explained in a very accessible way. And also people could share their experiences in a completely anonymous and private way. So I thank you now for the moment.
Thank you so much. And I'm sorry I had to interrupt. I'm gonna ask Dr. Padilla to briefly present to us her work on migration, and then we'll go to Q&A. Thank you.
Okay, I'll try to be very quick because there's not a lot of time. So I'll just be presenting briefly some findings that I published in a book and also in an article. So highlighting or bringing the issue of a European research project that was called UpWeb, and some specificities of the Portuguese case. This UpWeb project, UpWeb means understanding the practice and developing the concept of welfare bricolage. But when we talk about welfare in this project, we focus on health and try to relate and connect the welfare state or the welfare policies of this country with immigration models in the context of the super diversity, and in this case, super diversity relating to migration, maybe mainly the fact that mobility is taking place much more like at a faster pace, and that people and migrants are coming from more diverse places than ever before. So that is a concept that we use. And also trying to focus in the local dimension. So for a while, a lot of migration policies had been studying migration policies at the national level, but had not been looking into how that would take place in, at the city level or the municipality level. So in this project, we compare 4 different countries, the UK, Portugal, Germany, and Sweden, and focus in one city in each of them. So Birmingham, Lisbon, Bremen, and Uppsala. And our starting point was that the welfare state model in each of these 4 countries was very different. So if you know anything about the welfare state, was in the UK was a liberal model that maybe would be closer to the US, with the exception that it has a national health services. Portugal was the Southern European model, where the role of family and civil society is relevant. And then Germany will have a corporatist conservative model, more associated to specific insurance, and Sweden, a more democratic and universal system. Each of these countries will have also a different immigration regime. And in our context, it was very important to assess the austerity or not that was taking place in these countries. And also here, I'm just also sharing, I will not have time to explain, but the MIPEC, within the Migration Policy Index that is usually used. From here, you can see, or you will be able to see if you understood this, is that the issue of health in migration and as it relates to migration policy varies according to those countries. The general objective of the project was to investigate the factors that influence people access to healthcare services, and then by seeing people access, we compare natives or people of national origin versus also migrants and different type of migrants, their experience with healthcare providers in the context of national and local welfare states, health and migration regimes, including the different resources that they would pull even from abroad, which we call transnational health seeking in the context of the increasing transnationalism. And here we identify, I will not have time again to go over this, but we identify different type of healthcare, the health bricolage that residents develop, including migrants. We also explore the different ways or type that healthcare providers identify, how they identify the needs of the population, and investigating the role they adopt and the challenge and opportunities they face in the context, again, of diversity and inclusive migration. And finally, to advance a new method of collecting data about health welfare in super diverse spaces. So our methodology will, as you can see from this graph, it was very complex because it was very, it included a mixed methodology, qualitative and quantitative. The qualitative aspect included the in-depth interviews with residents, including migrants and non-migrants, in-depth interview also with healthcare providers. In the healthcare provider, we included a broad definition of healthcare providers, so not just doctors and nurses and psychologists and maybe social workers, but also people that would provide or help migrants to get access. Also people that work with holistic medicine, et cetera, et cetera. So having a broad definition of a healthcare in general. We did participant observation and street mapping, trying to map everything that was available in each of the neighborhoods, and also these mini ethnographies with the specific study cases to either get much more in-depth information from how people dealt what is that people did when they had a health problem. All this, the results from this informed the design of the survey. So we did a quantitative or the survey that was done in the 4 countries and in the 4 different cities and in the 8 different neighborhoods. In Lisbon, we did 600. And then we did a comparative analysis focusing on at the neighborhood level and the country levels. Our definition, so in this, we also had to define 2 different neighborhoods within a city that will have 2 different trends in terms of population growth, diversity, and some other social processes that were taking place in each neighborhood. And then, which I'll be talking a little bit more about, it was to bring some uniqueness of the Portuguese system. I had to be very quick. So 2 things or 2 concepts that we use and we developed was the idea of welfare bricolage, which we define as a creative mobilization, use and reuse of wide-ranging resources, including multiple knowledges, ideas, materials, and network in order to address a particular health concern. So we, in this sense, we identify a different kind of resources that were used by residents, including migrants, to address any health concerns, including the National Health Service and private providers, but also other set of resources, as you can see listed here, which I will not have time to provide to define. And then residents, in this sense, became, by using or by gathering these or mobilizing with bricolage, they became bricoleurs, so people that do the bricolage. We also focus, as I mentioned, on the healthcare provision as well, and the main challenge that they faced was the increasing diversity and the pace of change, with increasing barriers in language and communication, and a lot of distrust with the community and a lot of discrimination. But we also would find out, it was interesting that the health providers themselves also became bricoleurs, meaning that they were also combining different resources, different networkings. They would apply sometimes rule bending and sometimes discretionary power that could go, for the good or the bad, but in order to solve some of the problems. In the case of Portugal, what was the most striking, it was the austerity measures and the crisis that Portugal was facing. So that translated for Portugal with more bricolage, more networking, and more pooling resources together. So just to explain a little bit of the health provision in post-crisis Portugal had gone through the bailout. There was a huge economic crisis that was very different from the other 3 countries. And there was incredible cuts in welfare expenditure, especially in health, which was the most striking. So immense changes in the exemptions fees that existed, like the fees would double. There were a lot of cuts that were, in human and structural resources in the National Health Service, health workers burnout, salary cuts, a lot of new outsourcing of services for the National Health Service, which was, a neoliberal measure that did not happen before. So, and this after the Troika was over, the Troika was the bailout, no relevant changes were made. So this, the fact that none of this, the fact was that in this crisis, it was migrants who suffered the most, because while residents, national residents would get some exemptions or some solutions, migrants all of a sudden became excluded because of some of the changes that had been negotiated with during the bailout. So that translated in a deterioration of the National Health Service, the increase of irregularity and limbo situation, mainly for migrants that, supposed to have access, but were not able to have access, more bureaucracy, some loopholes in access, a lot of more problem with communications and language because of the end of existing good practices from before, and leading to more discrimination. So I will not have time to describe the neighborhoods, but these are the two neighborhoods that we focus was Morelia, this one, more with a lot of gentrification and a lot of changes going on, and Lumiar Alta de Lisboa, which shows some housing degradation, some more like mixing, but fortunately I can't explain it. So what I just want to share is two things. One is a timeline, this one that shows that we developed, that shows or has the advantages of showing in this slide, for example, the national, all the barriers and all the actors and all the ways that a migrant use to solve a health problem. Ava was from Pakistan and had a health problem, and it took her 8 months. And here you can see like all the different entities that either were a barrier or helped her to overcome a barrier. And I think I might have to leave it here because there's no more time. The other thing that I want you to say that was very, very relevant, the role of civil society in finding solutions for health care for migrants in order to solve their health issue. But there's no time for that. So let me show it end here.
So much. I wanted to take the last 3 minutes that we have precisely to discuss how do migrants access health. So I'm gonna head back to Dr. Villalón. If you could explain to us in 1 minute, please, how do migrants access health care? And then we'll close with Dr. Padilla with that same question, please.
Okay, I think that the main, actually, one of the main findings of the book was that they don't access healthcare, either because they have some fears or misinformation about where they could access healthcare, but mostly because in general, they deny their health conditions as a way of survival in the short run, right? But once they do, there's a difference in the case that I studied. For example, in Spain, they have an open or a public system that does not really require people to have any kind of documentation or insurance to be able to join and to access healthcare. So it's a little bit, it's much more open and accessible for migrants in Spain than it is in the United States, where you need to have documentation to be able to access, with a few exceptions, right? There's some clinics that are offering services for migrants, and there's very, very, very few public hospitals in some of the sanctuary cities that would also do the same.
Thank you. Dr. Padilla? Yes. So as I was saying, in Portugal and in Europe in general too, but in Portugal, Portugal has something that is the same thing that Spain has, is a national health service, and it has very good access and accessibility in general. But with this crisis, it was, that access was limited. So different NGOs or civil society organizations were key to improve access, either when it was denied, at least to argue, to advocate for them, or to provide some other services. So civil society was key in improving that. Portugal does not have any kind of deportation or mandatory reporting that, for example, Germany or other countries would have. So in that sense, there was not as much as a fear, but sometimes it's also not necessarily the fear, but sometimes not knowing. And this was, I mean, this is more clear or more evident when migrants recently arrived to the country. As migrants live in the country, they learn that they have more rights, but sometimes, you know, because their legal changes all the times that, you know, they might need to adjust. But that's why I just would like to insist that civil society play a relevant role. However, our conclusion for that article was that although NGOs are kind of a life vest for migrants to access health, that shouldn't be the case.
Thank you. Thank you both. This topic is definitely fascinating. I think we could stay here for a couple of days talking in depth about migration worldwide and access to healthcare. We know also, and we didn't get a chance to go into this topic, but I just wanted to mention it to our participants that violence is also an issue that affects migrants, and especially violence directed towards women. And we have been posting resources here in the chat for everyone. The presentation is recorded. You can find it in the Global Health Conversation series in YouTube. And you can access Dr. Villalón's book as well online, and all of the resources we have been sharing with you. We thank you for participating in this very interesting participation. Thank you, Dr. Villalón. Thank you, Dr. Padilla, for this very interesting conversation about migration. I wish we had more time, but maybe we'll have part 2 later on. So thank you so much. I don't know if you want to say anything before we close the presentation.
Thank you very much for having us here.
Thank you. Thank you. Take care, everyone. Bye-bye.